You can start.
Topic for the today's session is Neisseria and Moraxella. Neisseria, Moracella, Catarrhalis and Veillonella is a gram-negative cocci. So Neisseria are catalase positive and oxidase positive. Neisseria is a non-motile and aerobic gram-negative diplococci. So two species are pathogenic to humans. It will cause disease. One is Neisseria meningitis and other one is Neisseria gonorrhea. Others are common cells of intestine, genital tract or oral cavity. Difference between Neisseria meningitis and Neisseria gonorrhea. Neisseria meningitis is capsulated. Neisseria gonorrhea is non-capsulated. Neisseria meningitis is lens-shaped or half-moon shaped. Diplococci with adjacent sides are flattened. Neisseria gonorrhea is kidney-shaped. Diplococci with adjacent side is concave. Neisseria meningitis will ferment glucose and maltose. Neisseria gonorrhea will ferment only glucose. Neisseria meningitis, it will rarely have plasmid. Neisseria gonorrhea, usually it will have plasmid coding for drug-resistant genes. Neisseria meningitis, it will exist both in intra and extracellular forms. Neisseria gonorrhea, it will exist only in intracellular form. Neisseria meningitis, the colony is circular. In Neisseria gonorrhea, the colony will vary in size with irregular margin. Neisseria meningitis habitat is in nasopharynx, and in Neisseria gonorrhea, habitat is genital tract, mainly urethra and cervix. Rarely it is seen in pharynx. Neisseria meningitis is otherwise known as meningococcus. First one is the virulence factor, capsular polysaccharide. Capsular polysaccharide will prevent the bacteria from phagocytosis. It can be typed into 13 serogroups. Only 5 serogroups account for majority of cases. The 5 serogroups are A, B, C, Y, and W135. Other capsular serotypes and non-capsulated strains will colonize the nasopharynx of asymptomatic carriers. Only 60% of isolates are not capsulated. Outer membrane proteins. Outer membrane proteins is used to classify serogroups to serotype, lipopolysaccharide and endotoxin. Lipopolysaccharide and endotoxin, it will cause endothelial injury that will lead to increased vascular permeability, that will lead to loss of fluid, and finally to shock. Next one is the intravascular thrombosis that lead to disseminated intravascular coagulation, Waterhouse Friderichsen syndrome, and myocardial dysfunction. Immunoglobulin A protease, it will cleave mucosal immunoglobulin A, transferrin binding protein. Adhesin, it is mediated by colony opacity associated protein and pili. Next one is the epidemiology. In worldwide, nearly 5 lakh cases of meningococcal disease occur each year. Only 10% case death is seen. Disease pattern, there are several pattern of diseases noted. Epidemics, mainly it will occur in sub-Saharan Africa due to subgroup A mainly and W135 serotype. Outbreaks is mainly due to serogroup C. It is mainly seen in semi-closed communities such as schools, military camps, etc. Next one is the hyperendemic disease. More than 10 cases per 1 lakh population it is seen due to serogroup B. Sporadic cases, 0.3 to 5 cases per 1 lakh population can occur due to serotype A, B, C, Y, and W135. Higher prevalence area is sub-African belt of Africa from Ethiopia to Senegal. Seasonal variation is seen mainly during winter and spring season. So meningitis will mainly occur in childhood, mostly in from 3 months to 5 years. Risk factors that promote colonization include overcrowding and semi-closed communities such as schools, military, and refuge. and travelers, Hajj pilgrims, and smoking. Viral and mycoplasma infection of the respiratory tract. Deficiency of terminal complement components C5 to C9, hypogammaglobulinemia due to low serum immunoglobulin, hyposplenism due to reduced function of spleen. Next one is the pathogenesis. Source Most common source of infection is human nasopharyngeal carriers. Mainly the carriers are children. The carrier rate will vary from 5 to 10 percentage during inter-epidemic period due to up to 70 to 80 percentage during epidemic. Mode of transmission is mainly by droplet inhalation. Spread of infection is from nasopharynx. Meningococci will reach the meninges either by hematogenous route is the most common or by direct olfactory nerve spread through cribriform plate or rarely it will spread through conjunctiva. So the death ratio is 80 percentage. If the treatment is started means it will fall into 10 percentage. Clinical manifestation. Most of the cases are asymptomatic and rashes is seen in 80% of cases. And Waterhouse Friderichsen syndrome. It is one of the severe form of fulminant meningococcemia. It is characterized by purpuric rashes, shock, and adrenal hemorrhage, and in which the multiple organ failure will be there. And septicemia is seen. And pyogenic meningitis, it will affect mainly in children from age 3 to 5 years. And chronic meningococcemia, it is a rare condition in which rash, fever, arthritis, and splenomegaly is seen. Next one is the post meningococcal reactive disease. It is a immune complex. It will develop 4 to 10 days later. It will lead to arthritis, rash, pericarditis, and inflammation of synovial membrane, and fever will be there. Next one is a laboratory diagnosis. For cases, blood and cerebrospinal fluid is collected. For carriers, nasopharyngeal swab is taken. Steps of examination. First portion is centrifuge and used for capsular antigen detection. Under biochemical analysis, increased cerebrospinal fluid pressure and increased protein is seen, and glucose is decreased in cerebrospinal fluid. Under gram staining, pus cell with the gram negative diplococci, and it is seen as lens shaped. And second portion for culture on blood agar and chocolate agar. Third brain heart infusion broth, and it is incubated for 7 days. Nasopharyngeal swab culture and Thayer Martin medium. Next one is the biochemical test. It is oxidase and catalase positive, and it will ferment glucose maltose, and but it will not ferment sucrose. Serogrouping is done by latex agglutination test. Serology antibodies to capsular antigen ELISA useful in retrospective diagnosis of disease. Molecular diagnosis is done by multiplex PCR. Vaccine polyvalent vaccine containing 4 groups A, C, Y, W135. For serogroup B, no vaccine is available because it contains sialic acid residue, which is encephalotogenic, which means it is more prone to cause encephalitis, and it is purely immunogenic. However, outer membrane vesicles based vaccines trials are going on. Next one is the Neisseria gonorrhea. It is otherwise known as gonococcus. Neisseria gonorrhea is a non-capsulated gram-negative. It is kidney-shaped diplococci. Virulence factors pillae or fimbriae. Principal factor helps in adhesion, and it will inhibit the phagocytosis. Outer membrane protein, porin or protein 1, it will form a membrane channels or pores. There are two major serotypes, pore B1A and pore B1B serotype. Pore B1A strains is associated with local and disseminated gonococcal infection. Pore B1B strains usually cause local genital infections. Opacity associated protein Protein 2, it helps in adhesion and invasion, transferring binding and lactoferrin binding protein. It is essential from uptake of iron. Immunoglobulin A1 protease, it will degrade the mucosal immunoglobulin A antibody. Lipo-oligosaccharide, it differs from lipopolysaccharide of Endobacteriaceae by lacking the repetitive oocyte chain. Typing of gonococci. Serotyping is based on protein 1. Next one is the oxotyping. Typing is based on nutritional requirement of the strain. Oxotype needs arginine, hypoxanthine, and uracil as growth factors. Next one is the clinical manifestation of Neisseria gonorrhea. In male, acute urethritis is the most common manifestation. Purulent urethral discharge is seen. The word gonorrhea is derived from the flow of seed resembling semen. The usual incubation period of Neisseria gonorrhea is 2 to 7 days. The complication of Neisseria gonorrhea is epididymitis, prostatitis, edema of penis, and balanitis. Sometimes the infection may spread to periurethral tissue, causing abscess with sinus formation. It is also known as water can perineum. In females, gonococcal infection is less severe in females with more asymptomatic carriage. Mucopurulent cervicitis is the most common presentation in females with Neisseria gonorrhea. Vulvovaginitis seen in prepubertal girls and in postmenopausal women, but not in adult females, as the adult vagina is resistant to gonococcal infection. Salpingitis, pelvic inflammatory disease may lead to sterility. Fitzhugh-Curtis syndrome, it is rare and it is characterized by inflammation of peritoneum and associated with perihepatitis. And in both sexes, anorectal gonorrhea is as acute proctitis. Rectal isolates are usually due to drug resistance. Pharyngeal gonorrhea, it is spread by orogenital sex. And ocular gonorrhea, in neonates, ophthalmia neonatum is seen. It is characterized by purulent eye discharge. It will occur within 2 to 5 days after birth. Transmission occur from during birth from colonized maternal genital flora. Next one is the disseminated gonococcal infection. It will occur in 0.5 to 3% of untreated person. Disseminated gonococcal infection, it is characterized by polyarthritis and rarely dermatitis and endocarditis is seen. Most commonly, it is associated with poor B1A serotypes and AHU axotypes. Menstruation and complement deficiency are risk factor for disseminated gonococcal infection. In HIV infected person, it will enhances the transmission of HIV. Laboratory diagnosis, males urethral discharge is taken. For females, endocervical swab is taken. High vaginal swab is not recommended. For disseminated gonococcal infection, blood culture and synovial fluid culture is taken. Under transport media, charcoal impregnated swabs or medium stored amines media is used. For longer holding period, carbon dioxide generating system method is used. For gram staining, for males, gram staining of urethral discharge is more sensitive. 90% it is sensitive, based on which treatment can be started. For females, gram staining is less sensitive, 15 to 60% due to presence of commensal Neisseria species in genital tract. So in females, endocervical culture is recommended. Selective media are useful in chronic cases. They are Martin medium, modified New York City medium, Martin Lewis medium. Thank you.